evening, good afternoon, wherever you are in the world. We are on to the module 3 of tract urothelial cancer, and this is the second webinar on the module 3. As you know, that the program tonight is that Professor Laguna is going to talk about neoadjuvant and adjuvant chemotherapy, and there is a lot of data now in this regard, and she will try and summarize most of the salient details. This will be followed by a case presentation, and Dr. Yasir Rashid, who's our ex-chief resident, currently working in UK, will be presenting a case that we have managed a few years back. And myself and Professor Laguna are going to have comments, and we would like it to be as interactive as possible. So feel free to ask questions, write in the chat box, or raise your hand if you have any concern, because this is an interesting case in which we are going to talk about how to deal with this very interesting disease. And as usual, because this is the end of module 3, we'll have an end of module 3 post-test. Our main speaker tonight is Professor Pilar Laguna. I don't really need to say anything. She graduated from the beautiful city of Barcelona, the Familia Sagrada, and so many other monumental landmarks. She is currently a professor working in Istanbul in the Medipol University, over 350 publications, dozens of book chapters and books. She's currently also heading the testicular guideline panel of the EAU, very, very active in the SIU as well. So what we are going to talk about today is the challenges in the management of advanced UTUC. And we know that systemic treatment is the mainstay in this regard. However, one of the basic detriment to systemic therapy is the kidney function. And until very recently, we had evidence in favor of adjuvant treatment, and there is good quality literature available for the adjuvant treatment. But more recently, we have more evidence for neoadjuvant treatment as well. The cornerstone and the main stumbling block is the cisplatin eligibility. So that is one area where we will have to focus on because of the single functioning unit after radical nephroureterectomy. This and so many other aspects of this exciting disease will be discussed by Dr. Laguna. So, Professor, this screen is yours now. I'll stop sharing.
Perfect. Thank you very much to all of you. Welcome to, and let me see if it is sharing. Yeah, I will, Hamad, I will send you also. You already have this presentation. I make some very small changes, but I will send you after this afternoon, this night, in fact. I will send you this one and the previous one again by WeTransfer. If somebody is interested, I may respond to some of their questions.
Thank you very much.
You won't have it. Thank you. It's a neoadjuvant and adjuvant chemotherapy. And I must say that this is, I like very much testis cancer and UTUC, but I'm a little bit concerned that we are just, because we want to do good, we want to cure our patients, we want to have us with them with us as long as possible, and the families, of course, but we are just at some point messing a little bit. And we should be very careful with any kind of conclusion, especially regarding neoadjuvant and the new immunocheck inhibitors. So what's the situation? Well, you know, at presentation, in spite of the MRI, in spite of the advanced diagnosis and imaging, around 3/4 of half of the patients present already with high-grade and locally advanced disease. For all these patients, nephroureterectomy with bladder cuff excision is still the standard of care. We will see some concerns after. And in spite of this, the survival outcomes after 5 years of the nephroureterectomy are not really good, because between the 50 to 90% of the patients may be free, but The rest, of course, the differences and to the 100% maybe already with metastasis or any other site of recurrence. Intravesical recurrence is presented in 22 to 47, 50% of the patients, and cancer-specific survival is between 50 and 90%, and 35% only for those patients who have pathological invaded lymph nodes. Survival of COMS, this because the specific cancer-specific survival or overall survival are worse for patients with high grade and those patients who have locally advanced pathology at the moment of the radical nephroterectomy. It's clear that we need something just to improve these outcomes. And I would start by talking very briefly about two things who are important to the urologist as the surgeon, which is going to be doing the nephroureterectomies. So if you look at this slide, let me do this thing small, here. If you look at this slide, in the standard recommendations, we have to do a radical nephroureterectomy or a nephroureterectomy, and we have also to excise the bladder curve. And that's what we have been doing for years and years and years. But there is some data right now which is important to know. There are no differences in this paper, which is very recently published, no differences among techniques of bladder curve excision or between removal and not removal of the bladder curve incision in overall or in cancer-specific survival. What seems clear is that those patients, if you don't remove the bladder curve, they are going to have a higher rate of bladder recurrence. But be aware that whatever is the method that you use to remove the bladder curve, it seems that there are no differences in bladder recurrence-free survival or differences in recurrence-free survival or in metastasis-free survival. So whatever it is, it seems priority. Your patient is not going to die because you have not been removing the bladder curve, but you have to remove it because you are going to avoid morbidity, avoiding TURBs, and avoiding treatment of the bladder. The second point that I wanted to briefly discuss is about the lymphadenectomy. But it should be recommended, it is recommended in all guidelines in those patients who have high risk, high grade, non-metastatic UTUC. And it may be performed, which most of us don't do it, in low grade UTUC at the moment of the nephroureterectomy. Take into account that 1/3 of the patients who are categorized as high risk will already have regional positive lymph nodes, and this is, of course, the percentage much lower if you have a PT2 than if you have a PT4 or a PT3. There is quite at least 10 or 12 different templates to do these lymphadenectomies, and they are suggested. What they suggest in the guidelines is that we use one or another template, but we stick always to the template that we are doing. But there is still a big variation in the lymphadenectomy between institutions or even surgeons. Does it favor this lymphadenectomy? Does it result in a better survival? Well, we really don't know. You see here, this is one systematic reviews. I don't know what we will do right now without systematic reviews, which it seems that it favors the lymphadenectomy. It is still unclear because there are not really good prospective comparison between patients who receive lymphadenectomy or not, because of the big variation in the number of lymph nodes and because the templates are not always consistent or coordinated or agreeing among the different descriptions. Anyhow, it is recommended, and for sure in those PT2 it may be favored, maybe in some PT3 much more cautious, because probably in those patients with big PT3s or PT4 it's not going to be of benefit to do this lymphadenectomy, and then you can move in a morbidity. You have already Professor Atter presented it. You have two moments around the operation where you can treat the patient with chemotherapy. You can use it adjuvant after the nephrectomy. You base your indication in the histopathology, and we do have level 1 of evidence, and that is very important. But only this evidence is only related to the cisplatin-based chemotherapy. If you have not been treating the patients, and if you have not yet been operating the patients, then you can opt for choosing the neoadjuvant chemotherapy. The problem here is that we don't have a very good, accurate prediction model who can tell you this is a T2, or who can discriminate between some T1s and T2s and T2s and T3. And not all patients, so you risk just to overtreat this patient with this neoadjuvant chemotherapy. The advantage, of course, is that you can treat the micrometastasis, and that the patient, most of the patients, well, not most of the patients, but around 55-60% of those patients, take into account that there are all patients with comorbidity, but at least 50 or 60 you will be able to administer cisplatin and the full dose of cisplatin. There is mixed evidence in neoadjuvant, and that's what you have to keep in mind. And what we have level 1 for bladder cancer, we have been extrapolating all the results in bladder cancer to the UTUC, and they are very similar. They are brothers, but even between brothers, there may be differences. Be careful once you decide on the time of this chemotherapy, because there are no clear recommendations on the guidelines, and the high-risk categorization is discordant among guidelines. There is an example also in a recent series published, the Robust, coming from North America, but also with some including some European patients, which once you categorize the risk, there is a discordance who amounts for 15%. So you can have a patient which is high risk according to the EAU categorization, but not according to the NCCN or the AUA guidelines. 50% of disagreement, it looks quite high to decide on treat or not to treat in the neoadjuvant setting. I think that Panchai already presented this table, which is a nice table, and tells you in which moment you can. It's about when and how you manage the patients with UTUC, or the high-risk patients, and also include some of them with low risk. And it's good, was published in 2024, and I guess that it was just, the paper was just written in 23, because there are some things who have been changing in 24. For example, if you see about neoadjuvant platinum-based chemotherapy, AUA and the Society of Urological I don't know for what comes the or right now. It doesn't come. Society of Urological Oncologists. Yes. And then the NCCN, they give you some clues about when you can use or you should use the neoadjuvant. But the EAU, although they talk about neoadjuvant cisplatin-based chemotherapy, they is not even mentioned in the recommendations, and not even mentioned in the state of the question of how it's very vague, what they write about the neoadjuvant chemotherapy. If you look at the immunotherapy in high risk, you see here no specification. Well, actually, in 2024, the three guidelines discuss, maybe offer or consider, this is semantics, adjuvant nivolumab with patients unfit or declining, for whatever reason, adjuvant platinum-based chemotherapy for PT3 and or positive lymph nodes. And irrespective of if the patient has been responding or not responding to if there is downgrading in the radical nephrectomies. talking about this, and that was a consistent recommendation, and it's the first one that we have to take into account. Always after the operation, after the nephrorectomy, and for this we have evidence grade 1, 2 randomized controlled trials. One is phase 2 and another one is phase 3, that the single instillation of pirarubicin or adriamycin or mitomycin is effective in decreasing the bladder recurrence in patients who had no previous history of bladder cancer. Whether you do it the 24, 48 hours, it seems that it can be delayed safely 1 week or 10 days with exactly the same effect. So this is just to show you that mitomycin versus no mitomycin has a very difference in the first year in the rate of bladder recurrences. So please do not forget, do it at the moment that the patient is not bleeding anymore, and do it at the moment that you are sure that this bladder is closed. So you can safely delay this for up to 10 days after the operation. If you look at the neoadjuvant, and this is probably one of the best systematic reviews in the literature, well, there is a benefit for adjuvant chemotherapy. 23% of the patients benefit from this treatment, adjuvant, after the nephrorectomy, and if you compare with those patients that don't have adjuvant chemotherapy. If you look at the cancer-specific survival, practically the same. 21% of the patients benefit from adjuvant chemotherapy over nephrorectomy alone. If you look at the disease-free survival, things are a little bit different, but it seems that indeed that it may be also the simple reason why it's not calculated in this systematic review. The benefit is because there is no enough number of patients. You know that the patients in a systematic review of retrospective data, it can be that you don't have some statistics is better not to apply because are going to confound us. It seems to be a trend to a better disease-free survival, but it's not calculated the extension of this benefit. And the same happens with the recurrence-free survival. But this was published in 2020 and mostly were retrospective studies. And we have to be very careful with all these retrospective studies, how you read them, how you analyze them, and how you interpret it. In 2020, the PAUS trial was published, and that changed completely the scenario of the adjuvant chemotherapy after nephrorectomy. This is a randomized control trial who was just randomizing the patients to receive gemcitabine plus cisplatin or carboplatin, depending on the eGFR, versus active surveillance after nephrorectomy. And this treatment could be initiated up to 90 days, which is 3 months after the nephrorectomy, meaning that the patient was already recuperating the definitive function, and you could treat some of them with cisplatin. And the other that were not having a good eGFR, I think was lower than 50, then they were receiving carboplatin. The patients who were included had no metastasis, and they could have, of course, whatever stage, PT2 to 4, and whatever patient who has a positive node in this study. 94% of the participants have PT2, PT3, but one of the tricks of the study is that 68% of patients did not receive any lymphadenectomy, whether for historical reasons or whether the surgeon was not thinking it to be appropriate. The primary endpoint was the disease-free survival. On the right side, there is just the flow chart of the study that you don't need to get it by memory. That's why you have the literature, but actually it was, they included 261 patients, who was a good number, and the power calculation was very correct. 68% of the patients who were randomized to the chemotherapy arm received cisplatin, and the other the other 32% was receiving carboplatin, and then indeed 2/3 of the patients who were allotted to the cisplatin were able to tolerate the 4 cycles who were in the protocol. There was a significant benefit of the chemotherapy in disease-free survival at the median follow-up of 30 months. Who was the disease-free survival? 3-year disease-free survival was 71 in the group who received the chemotherapy versus 46% in the group in active surveillance that didn't receive, of course, any treatment at this moment. They went for some subgroup, and in fact, it seems that adjuvant chemotherapy would improve this disease-free survival in those patients who had negative lymph nodes. But the trial was not powered for any subgroup analysis, and only 10% of the patients had lymphadenectomy, and very few of the patients were a positive lymph nodes, and very few of these patients were just receiving a lymphadenectomy. So there was no benefit observed in patients with positive lymph nodes, and the number of adverse events who were related to chemotherapy, as expected, was much more higher than in those that receive surveillance. But there was also no differences between carboplatin or cisplatin. By the way, the study was just closed before including the initial number of patients, because the committee consider that the endpoint of the study, or the difference in disease-free survival, was already reached, and then there was no reason to continue randomizing patients. There were also no differences in quality of life. They just assessed the quality of life with validated questionnaires, and there was indeed, in those patients who received chemotherapy, there was a decrease in the quality of life during the first 6 months, but that never overcome the minimum important clinical differences, who are very is what you have to look at when you are assessing the quality of life. Well, that were the things until very recently, because very recently, the 5 years follow-up of the same study has been published. It's a short article which is easy to read, so I should recommend it to you, and you can see in the article very clear. But the benefit of the adjuvant chemotherapy is maintained at 5 years. And it's significant in favor of the chemotherapy, and that there is a trend that favors also the adjuvant chemotherapy in overall survival, which is a much better objective, much better primary endpoint than the disease-free survival. Sometimes we use the disease-free survival just as a proxy of overall survival, but that may not be repeated, may not be consistent. Between 6 and 24 months, also the important, or the grade 3 or higher of adverse events was similar in low in 2 arms, and again there were no differences in quality of life up to 24 months. What's the problem with the cisplatin? And already Professor Attar has been just showing you. The problem with the cisplatin is that those are all patients with comorbidity. So before operating, already 42% of them are not eligible for cisplatin based on the EGFR and the comorbidity. But once you take the kidney with the disease, then only this goes rapidly down, and only 15% of the patients may receive cisplatin. Then if they cannot receive cisplatin, now obviously we have at this moment the new targeted therapies and even much better the inhibitors, the checkpoint inhibitors. There are 3 studies, phase 3, who are assessing the role of the adjuvant immunotherapy in urothelial cancer. And I only put you 2 here because the first one, all the 3 studies are studies for urothelial cancer. So the majority of the patients that have been included are patients with receiving radical cystectomy because of bladder cancer. So the number or whatever we are extrapolating is from bladder cancer may or may not be true in upper urinary tract. And if you see, for example, and all these studies in Vigor, Ambassador, and the key the keynote study, then all them are absolutely empowered to calculate what is happening with the UTUC. You see one on the left side in Vigor, which is just testing atezolizumab versus observation. Only 54 patients, 6.6% of all the patients had UTUC. And this, it was just, I think it's not this one, it's the other one that I'm presenting. But if you look at the distribution, is exactly the same, or the plots are exactly the same in the 3 studies. Yes, there is effect of atezolizumab in urothelial cancer, but it's not. Look in this one. This one is with pembro, but it's exactly the same, and this has been just published a couple of weeks ago. So there is an advantage on giving atezolizumab or pembrolizumab in urothelial cancer in general, but there is not advantage in the upper urinary tract. And this plot repeats this plot, which there is favoring observation, but in fact means that there is not favoring the immunocheckpoint, repeats systematically in the 3 studies. In Vigor, Ambassador, which is using pembrolizumab with more patients, and in the Checkmate 274, which is using the nivolumab. So why? You can see here the plot also in these patients. Why is the nivolumab? Because if you go to the guidelines, you will see that nivolumab is really recommended or is accepted as an alternative to cisplatin or carboplatin. Why is it recommended in UTUC? Well, I've been reading and trying to find a rationale from this. I can only tell you the FDA was approving it almost 1 year before. In April 22, EMA, the European Medical Agency, was approving the nivolumab in patients with muscle-invasive urothelial cancer with tumor cell with PD-L1 expression above 1%. When in high risk of recurrence and fit or declining cisplatin-based chemotherapy. And the only reason that I can find is that we didn't have at this moment, and we still do not have any other valuable option for those patients who cannot receive or don't want to receive cisplatin. We have to wait what's going to happen with these patients who are receiving nivolumab, because it's already using in practice, and we will see. But that is going to take UTUC is a rare disease, so this is going to take us some years. And with this, we move to the neoadjuvant. Neoadjuvant means you make the diagnosis, you make the categorization. Maybe it's correct, it's what you are going to find in the pathology. Maybe it is not, you do not know. We do not reevaluate these patients like in bladder cancer, but it's clear. The first graphic is coming from Japan, the second one is coming from the United States. It's clear that the use of neoadjuvant has been just increasing all over the world. Control, not control. Some of these patients have been published, the studies have been published. Some other is just they just use it in clinical practice. We don't have control about this, but that's the case, and probably is also the same that may happen in Pakistan or in Turkey at this moment. What is important is to know if we can really extrapolate the data from the bladder cancer. And this is an interesting study which just compares responses, pathological objective response and pathological complete response in bladder cancer and in UTUC. And it seems that they are similar, either the pathological and the objective means that there is response, and complete response is that you find something which is zero, PT0. It means that these percentages are quite similar. In this study, at least, the cancer-specific survival remain associated to UTUC advantage only is evident in patients with pathological overall response, objective response. Sorry. Yeah. I see here that the PAS, this is something also that I was looking, that the PAS are significant. Please don't take this seriously, this PAS, because the number of patients who was included in one and the other were different. The characteristics of the patients were already different, and probably this study is a retrospective study, should not have been comparing almost 1,300 patients with 276. And then there were there may have been some problems with the pathological interpretation of the data. What is important in the neoadjuvant evaluation is that we have to use the same definitions, and some of these definitions are still discussed, and the different groups may not use the same definition. Survival outcomes, time to even endpoint at subsequent therapy, or even free survival, they should be much better than the different definitions of survival that we have been using up to now. Pathological outcomes as a surrogate of success, yes, in some articles, not always. The fact that there is a pathological response is going to translate in a survival outcome. Radiological endpoints, remember that we are still assessing most of these patients with CT, with cross-sectional imaging, and in this is only the RECIST that you are going to use. This isn't reliable in UTUC, and we have to move to molecular imaging. And then, of course, safety, compliance, and quality of life are important points to be assessed and to be taken into account once you are going to assess or evaluate the benefit of a neoadjuvant evaluation. Again, coming back to the systematic review of Leo in 2020, I think it was 2020 or 2020, yes. Then you will see that the response to the neoadjuvant chemotherapy, well, in this review is 11%, but others have been, even in other systematic reviews, they have been publishing pathological complete responses from 0 to 28%, and pathological partial responses between 33 and 80%. Pathological downstaging in around 1/3 of the patients. That seems, this last concept seems to me much more acceptable, that a wide margin between 33 and 80% of pathological responses, and in favor of a neoadjuvant chemotherapy, the fact that it seems that there is a great benefit, around 56% in overall survival. That should be fantastic. And again, in cancer-specific survival, 62%. Again, once again, most of these studies were just retrospective and published before the implementation before adopting the cisplatin as a possibility of a neoadjuvant treatment. So it seems that yes, there are down stages, but patients are selected, and the regimens that these patients have been receiving were unclear. So, and the evidence is far away from one. Which are the patients who are selected or who have been selected in retrospective studies? We do not have randomized control trials yet. Patients that are receiving neoadjuvant chemotherapy are younger than the ones who are just going directly for nephroureterectomy, are more healthy, fewer comorbidities, they will have a lower CKD, less likely to have hydronephrosis or multifocality, higher CT end stages, more likely to have previous cystectomy, and more likely to receive the nephroureterectomy after 2009. But a lot of regimes have been using either gemcitabine with cisplatin, MVAC, the old MVAC, cisplatin, with gemcitabine, and adding the eufosfamide. Also, taxols have been using, and in fact, there is very difficult to get a clear view of what has been happening. Recurrence and overall survival, there is a trend. It seems to be better, but it's not conclusive with neoadjuvant treatment, chemotherapy, in fact, most of them, and it's true that it seems associated with an improving cancer-specific survival. This is the most recent data. It's coming from the National Cancer Database. There is an enormous amount of patients included. Most of them or most of the conclusions are related to demographic characteristics of the patient, but it gives you a good overall of those patients who receive neoadjuvant chemotherapy. Again, diverse regimes, diverse schedules, and diverse patients. This second article confirms exactly the selection. There are very selected patients, the same selection that we just mentioned 1 minute ago. And you see here that there is a big difference on the right side in the overall survival between those patients who have no response, those patients which have a partial pathological response, and those patients who have T0s or complete responses, with much better. 3 studies, there are a little bit more, but those 3 are worth to mention. The 3 of them are phase 2 trials of neoadjuvant systemic chemotherapy. One of them is using accelerated MVAC and carboplatin and gemcitabine. The other one, which is probably one of the best studies, is coming from the Memorial Sloan Kettering. A little bit more patients. There were 30 only included in the first one, 57 in this. Favorable survival outcomes, and in this case, a pathological complete response and pathological partial response are associated with improved progression-free survival and overall survival. It's a phase 2. It's mostly in efficacy and in safety, and we miss here again the randomized. I must say there is a small study who was following the PURE 1, is the PURE 2 study, which only 10 patients included treated with pembrolizumab, and there was practically no responses. But it's worth to keep in mind this graphic, which is the one coming from the study of the Memorial Sloan Kettering, and you see that there is a big difference between those patients who do not respond and the patients who respond or have a partial response in terms of progression-free survival. What's going to happen with the neoadjuvant? Well, this is only a part of all, or a portion of all the studies that you can find in the literature, ongoing studies at this moment. You have phase 1b immunotherapy and chemotherapy, and you can see here that this study is just using the infigratinib, which is just an inhibitor of the fibroblast growing factor reception, phase 2 immunotherapy, a lot of them, phase 3 immunotherapy plus comparing with chemotherapy. In some of them, and no one of them yet is expected to be published before 2 or 3 years. Even the Uranus that I think that was open in 2018, something like this, still nothing is in the literature. So we have to wait. Probably we have we will have to study all these patients, not only under the clinical point of view, but until the molecular point of view, and determine which patient has to receive what. And again, this is not going to be easy, and probably is going to happen the same that has been happening in blood or in kidney cancer, that once we have the response, already new medication, new targets are defined, and new drugs are implemented in clinical practice before hard evidence that they work or not. In conclusion, perioperative systemic treatment of high-risk UTUC remains still a challenge. Level 1 of evidence supports the use of cisplatin-based adjuvant chemotherapy, and the benefit of nivolumab in adjuvant setting is extrapolated from bladder cancer trials and should be restricted to selected patients. We don't know very well how to select these patients yet in a prospective way. A neoadjuvant chemotherapy expands, of course, the pool of patients that can be safely treated with cisplatin, increases the rate of pathological downstaging, and seems to result in longer overall survival and cancer-specific survival. But I wouldn't be very enthusiastic supporting this until more data comes to the literature. However, the evidence surrounding the use of NAC is low, and multiple phase 1 to phase 3 trials are ongoing with checkpoint inhibitors of the last generation targeting specific mutations and assessing the potential role of immunobiomarkers. Thank you very much for your attention. I think that I went a little bit too much. And please send me, I didn't check it, but send me if you have am I here or am I not here?
Thank you very much, Dr. Laguna. I think there's a lot of scattered data, and you have really done justice in only 35 minutes. You have very comprehensively covered all what is available, every level of evidence available for this rather rare disease. So with this, we move on to the next part of today's presentation, which is a case. And we are very fortunate to have Dr. Laguna, besides Dr. Pankaj Maheshwari, who presented in the last webinar, is also there, and Mustafa Nandwani is also there. So if there are any questions, comments, please feel free to post them on the chat box or raise your hand, and we'll give you an opportunity to ask questions from our panelists. It's my pleasure to invite my ex-chief resident and now working as a consultant in NHS in UK, in Scotland, Dr. Yasir Rashid. He will be presenting this case, which we managed together some years back. So Yasir, the screen is yours.
Thank you very much, Professor Ahmad, and I'm very honored to be presenting over here. For all the participants, this will be an interactive presentation, and we have a panel of experts over here. So I think we should all take good use of this opportunity. So at any point, if you feel that this is a detailed case involving UTUC, so if you feel that you want to understand any one perspective of why this particular step was done, or anything different could have been done at that point of view, you're welcome to post your questions, and hopefully we'll be able to take it then and there. Is my screen visible? Yeah. Okay. So this is a 73-year-old gentleman who presented initially for an evaluation for right hydronephrosis and hydroureter, which was seen on an ultrasound scan because the patient was having some lower urinary tract symptoms for around 1 year. So this was a screening ultrasound scan done. Along with that, it was also noted that his renal function was going down constantly. So this is around 1 year history of lower urinary tract symptoms, past history of diabetes, hypertension, ischemic heart disease, had one intervention for his coronary ischemic heart disease. There was no family history of any cancers and no personal history of any addictions. On examination at the initial evaluation, it was unremarkable. Since his creatinine at the presentation was significantly high, it was about 1.6 and had constantly been declining over the past few months, so a CT was not done at the initial presentation. The baseline workup showed that hemoglobin was within normal range. Creatinine, as I mentioned earlier, was significantly high. It was a good quality ultrasound. We could trace the ureter all the way, and the radiologist could mention that it was dilated ureter as well at the same time. A pre-void volume of 160, post-void was okay. Initially, cytology was also performed, which showed high-grade results. So this patient was taken to the operating room under general anesthetic. Retrograde study was performed. Cystoscopy was done. With that, ureteroscopy was done. A lesion was seen in the distal ureter, which was biopsied, and the results of the biopsy showed high-grade papillary urothelial carcinoma. With carcinoma in situ, there was no convincing evidence of muscularis propria invasion. It was not identified initially in the biopsy. Sorry, I'm just having a bit of trouble with my technology. Just give me a minute. Okay. A PET scan was performed once we had done this biopsy, and this initial PET scan did not show any other significant disease. There were a few pulmonary nodes noted, but they were too small to be categorized as significant. So just a follow-up was recommended for these pulmonary nodes. There was no other disease, and this was a PET scan which was taken with oral gastrographin, so it was uniformly distributed. No other lesions were noted. Patient underwent right nephroureterectomy with bladder cuff excision. This was an open surgery. Patient had an unremarkable recovery. He was discharged on the fourth day after surgery. Trial without catheter was given after around 10 days, 2 weeks' time, and that was also successful. The histopathology showed T3 high-grade invasive urothelial cancer in the ureter. This is the detailed histopathology. The tumor size was about 4.5 into 2 into 0.8 centimeter. It's invasive urothelial carcinoma with high grade. It did extend beyond the muscle into the periureteric fat, and the stage given pathologically was T3. There was also lymphovascular invasion present in the final histopathology.
Yes, sir, if I can stop you at this point, and let me ask Dr. Laguna. Obviously, this patient has a raised creatinine, so he is cisplatin ineligible. He has a history of ischemic heart disease. That's another contraindication. We have not done the NYHA classification, so I'm not really sure which group he belongs to. So, I mean, while counseling these patients before the radical nephroureterectomy, how would you justify not doing any systemic treatment in this situation?
With one of the things is that it's very easy to do conclusions or to not criticize. I mean, with in a good sense, something which is retrospective. I think that probably this patient, if it could have treated now, knowing that it's 73 that has a relative more comorbidity. And this tumor seems to be a big tumor, and there for a long time there are already kinkings in the ureter. You know that this is a high grade, you know that the cytology is, you know that this is a high risk tumor. I think that this patient is the one that I will choose to discuss with him neoadjuvant chemotherapy. Because he's going to lose at least 30% of the renal function after the nephrectomy. We know it, that even in healthy people, in donors, they lose 30% of the renal function. Nothing happens because they are young, because they are healthy, etc., etc. But in this patient, it's not going to be easy. So I will discuss with him, and I will discuss cisplatin. I know that there has not been demonstrated any difference between cisplatin and carboplatin. We have experience with carboplatin in the bladder, and we know that it's not working as good as the cisplatin. So, if possible, I would give to this patient cisplatin, and if for whatever reason he didn't want to have a cisplatin, I think that he had an acceptable EGFR before the nephrectomy, then probably I will call to some of my friends who are in a clinical trial, and I will put in a clinical trial, because this is one thing which I think is very important, especially in the time that we are living. We are not treating patients in United States. We don't have the same resources as they have, but there are still trials, and we should take maximum benefit, always talking to the patient, of course, of put these patients in a trial and to try to contribute to the advance of the medicine. So to make it very short, I will discuss with him neoadjuvant chemotherapy. Now, in 2025, probably not at that time, because still we didn't know so much.
Yeah. Thank you. Yasir, you may continue, please. Thank you.
Thank you very much. This is a post-operative PET scan from December 2021, which again did not show any evidence of any metastatic disease. A small collection was noted at the nephrectomy bed on the right side, but there was no avidity noted. The nodules in the lung were pretty much stable. This is a cystoscopy which was done at around 3 months after the nephrectomy, and it did show the cytology before the cystoscopy showed some atypical cells. Check cystoscopy showed 2 small papillary lesions on the posterior wall of the bladder. These were resected, and the histopathology showed high-grade invasive urothelial cancer in the bladder. This is 3 months after the original surgery. At this point, patient was discussed in the tumor board, and chemotherapy was suggested for the patient. His creatinine at this point has further raised to around 2.1. Carboplatin with gemcitabine was suggested, and 4 cycles were given to the patient. Fast forward to around 7 to 8 months after the nephrectomy, another check cystoscopy was done, and cytology was done at the same time, which did not show any evidence of recurrence in the bladder. This was followed up with another PET-CT scan at around 10 months, which showed that there was interval appearance of retrocaval, aortocaval, and liver metastasis. Cytology was also showing atypical cells. At this point, the patient is post 4 cycles of chemotherapy. This is around 10 months from the original surgery, and there are now metastases seen in the nodes as well as liver. Case was again discussed in the tumor board MDT, and this time immunotherapy, pembrolizumab, was suggested. This was started. Around 4 cycles of pembrolizumab were given, and then the patient developed hematuria. This was between the 3rd and 4th cycle. Another cystoscopy was performed. At this point, there was a 2 centimeter posterior bladder wall growth. This is around 12 months now post nephrectomy. This histopathology from the bladder tumor showed a high-grade non-invasive urothelial carcinoma. Detrusor muscle was seen. It was free of tumor. Postoperatively, single installation was given, and patient was started on BCG.
So I think let's take a break here and let me ask Pankaj. Now, we're dealing with a patient who has a recurrence of disease in the abdomen with lymphadenopathy following carboplatin gemcitabine. Now, he also has disease in the bladder. So would you consider these two entities and treat them separately as two entities, or you think that intravesical treatment is probably not really going to be effective in the phase of a metastatic disease?
So it's a difficult question, but I would still treat them as different, and I would give intravesical chemotherapy, especially because intravesical BCG, especially because the disease in the bladder doesn't appear to be muscle invasive, and treat the UTUC metastasis on merit based on how the patient's overall condition is.
Dr. Laguna, any comments on this?
Nope, I will do the same because this is not going well with this patient. So you know that actually with the pembrolizumab there is no evidence that this the only study is the one I show you with 10 patients, and it was completely negative. Of course, 10 patients, it's not enough. But anyhow, I would do exactly the same as Pankaj, and just to try to preserve the bladder and to see if I mean, to do a cystectomy in this stage is not something that the patient is going to be very it's going to have a big benefit, and I will try to control this with treating the bladder. It's a high grade. You can give BCG, but you can also give mitomycin, which is going to be probably producing less comorbidity, less local comorbidity, and then you make comfort for the patient. I would like to ask you something, Hamad, because I think that I missed something about this patient and to your ex-resident. Sorry that I don't have the name. What was the EGFR? Because I saw that there was a question there about the MRI, and that the MRI was not done because the EGFR was, what was before?
It was the creatinine was 1.6 and the EGFR was about 35.
35. What still you
Yeah.
can cisplatin or carboplatin, yeah, but is true. You cannot do, responding to the question of the room, you cannot do the MRI. You are not going to see anything, or you are going to cause harm to the patient. With 35, because we were talking about neoadjuvant, still with 35, you can give cisplatin or carboplatin. Probably, and I think that Pankaj will be agreeing with me. Right now, we will just give him nivolumab because we are giving a lot of things without evidence, but still we can give neoadjuvant chemotherapy. After this, I see that he receives cisplatin base, but after the nephrectomy, he's not going to be resisting. He's going to have problems. Okay.
Thanks. Yes, sir, please.
Yes, sir.
All right, thank you. Okay, my screen, that's not moving. Sorry about that. It's just giving me some trouble with moving the slides.
Yes, sir. I thought that I was the only one who has always trouble with that.
Well,
In the meantime, while you are sorting the slides out, there is a question about lymphadenectomy, and Dr. Laguna has mentioned in a presentation about a significant variation in the practice of doing lymphadenectomy. So various centers, various surgeons have different preferences in doing nephrectomy. And now, since we have a nodal disease, there is a question in the chat box that why a lymphadenectomy was not performed in this case. So as you have seen in Dr. Laguna's presentation, that lymphadenectomy is not considered as an essential part of radical nephroureterectomy. Although if you look at in retrospectively, you probably would be wiser if you have done the lymphadenectomy. Dr. Pankaj, Dr. Laguna, any comments on this?
Pankaj, you first.
You see, as Madam Laguna has said, that retrospectively we are always wiser. Yes, in my center we always do regional lymphadenectomy with radical nephrectomy. At least it gives us a good staging at that time, even if it is not therapeutic, if it doesn't give us a therapeutic advantage.
Right. Yes, are
I-
you ready?
I
Great.
Yeah,
believe
yeah, Dr. Laguna.
I believe that the lymphadenectomy, that we have to make efforts to do this lymphadenectomy, at least to know what are we dealing with. The problem here is that there is no standard, there is no template who has been showing any advantage over any other one, and that we are dealing with all patients, so you can create morbidity, and that's what you don't want in those patients. But I'm a defendant of the lymphadenectomy, even if it is only for staging purposes. So once you have to treat after, you should know what you are treating. If not, anyhow, Yasser.
Thank you. Moving on, this is around 1 year from the original surgery. We have the second recurrence in the bladder, and this is the PET CT scan. This is after 4 cycles of carboplatin-based chemotherapy and 4 cycles of pembrolizumab. This fresh PET CT scan again showed there was increase in previously seen metastasis in the retroperitoneum. You can see a lot of nodes in the retroperitoneum, and then you can also see that there is a large lesion in the liver now. Patient was taken to the MDT again, and this time he was started on paclitaxel. Now, moving on to about 15 months post nephrectomy, we had another cystoscopy. This is the 4th cystoscopy, and the patient had clear cystoscopy this time. Random biopsies were done, which were again negative. At this time, interestingly, the patient had developed a nodule on the right upper abdomen, which was a small 2 to 3 centimeter nodule, and it did appear initially that it might have something to do with the disease. In the same setting as cystoscopy, we did take that one out as well, although the final histopathology did not show that it was there was any evidence of malignancy in that. At this point, an interval PET CT scan showed interval response. You can see on the screen that the nodes in the retroperitoneum have virtually disappeared, and the liver lesion has also significantly reduced in size. Although there was a new lesion in the L3 vertebral body and a new node in the right lung. Minded, the lung nodules for the past 1.5 years were almost stable, but there was this new nodule that was now seen in the lung, and a new vertebral body lesion, despite being on paclitaxel, although the other nodes had decreased in size. So this is the current status of the patient. It will be discussed further in the MDTs, and one of the options coming up on surface is also to consider radiotherapy for that vertebral lesion that is now seen on the PET scan. Thank you very much.
So he became symptomatic. Yasser has now left Karachi and has gone to UK. So I've been treating this patient. The spinal nodule became very symptomatic. He had difficulty in walking. So SBRT was done for that nodule. Responded quite well with SBRT, and his bladder is clear. His lymphadenopathy and the liver lesions are stable, and he refused any further chemotherapy. So this is the current status.
Thank you very much.
So, I mean, quite a few lessons from this case, and I would ask Pankaj to please comment first, and then Dr. Laguna.
So this case definitely shows that UTUC is an extremely aggressive disease, and being aggressive from the time we diagnose it is probably the best way to treat these patients. Once they start getting into metastatic phase, then really the treatment options keep on becoming limited with solitary kidney, and probably neoadjuvant chemotherapy is something which may have changed the course of this patient's treatment. But yes, this shows that UTUC is a bad disease to have.
Dr. Laguna.
I agree. I agree with Panchai. I wanted to ask you something, which is maybe I'm a little bit obsessed with everything, which is definition. So you present in one of the last slides very good. So you say there are no lymph nodes. Well, the lymph nodes didn't disappear. There are not hot in the not hot spots, but they are there. And then, but that's good, disappear. But then this patient develop new metastases. So how do your nuclear guys categorize this? Is this a partial response? Is this it cannot be a complete response? Is this a progression? Because still, this is one of the things that we have, one of the lessons that we have learning from all this, that if we use different definitions, we will never be able to clearly define the outcome. And still at this moment, we have difficulties in defining molecular imaging. And even what we have, which is the maximum, which is the FDG PET scan, you know that how many types of FDG PET scan are right now already accepted by the FDA of the EMA. So we do not know exactly which is the ideal test or the ideal imaging to look at those patients. So,
I mean, from the nuclear reporting perspective, if I exactly read their words, they've mentioned that this is an abnormal follow-up study with interval regression in the post-surgical collection, interval regression in the retrocaval aortocaval nodes, greater than 30% regression, interval regression in the hypermetabolic hypodense liver mets, and then new appearance of nodules in the left in the lung lobe and L3 vertebral body. So I've called it. They haven't really used the word partial or complete, but they've mentioned these separately.
There is a very diplomatic, I have to quote, very diplomatic and non-committal.
I mean, these are radiologists we are dealing with, so.
No, I tell you, because if you say this is a progression, you just talk to the patient and probably you go for a palliation. But this patient is still alive 4 years after.
Yeah.
So everything who has been done has been worthwhile. It's true that there was no microsatellite instability at some of the mutations, like the FGFR3 that we think right now that is important, were not observed. You know, it's true, but still we are like newborns in everything which is related to upper urinary tract. So, and before we get something, artificial intelligence is coming and is going to tell you what's going to happen.
True. I see Mustafa Nandwani's hand raised. Mustafa, please carry on. Unmute yourself, please.
Yeah. So hi. Actually, I wanted to ask the panel actually because with these like patients who present with the partial obstruction or complete obstruction with the the upper tract urothelial cancer, and you have a low GFR. So do you guys consider doing the DMSA to see the differential function? And if they are being considered for neoadjuvant, and if the main functioning kidney is towards where the cancer is, do you consider putting the stent or any diversion if they are suitable for neoadjuvant? So that was the question that I had.
Dr. Laguna?
Maybe, but the problem of touching the urothelial cancer, upper urinary urothelial cancer, with draining this, is that you are always afraid that this is going to grow, this is going to progress, etc., etc. But it may be it may be an option. I've never been facing this, but it may be an option. But the DMSA is a good idea, and is a good management planning, because you may also have a kidney which is almost contributing very few to the total renal function, and then you can still treat the patient.
Even I would feel that if the kidney is obstructed, probably placing a stent, especially in the time period when we are giving neoadjuvant chemotherapy, would be a good idea.
Yeah. So, I mean, from the discussion so far, it's quite clear that we still don't know a lot about this disease. It's because there is very little evidence. There are very few high quality studies, only because it's such a rare condition that you don't see them so frequently. And it has to be accumulative evidence coming from various centers in order to develop some strategies of dealing with the situation. So in my personal opinion, at that time when he actually presented 70 plus ischemic heart disease, I think previously had angioplasty as well, and his GFR was low. I thought that if I do a clear margin resection, probably he may avoid chemotherapy. However, obviously it didn't happen that way, and he continued to have one disease after another one. So I think just explains how complicated this condition is, and there is so little evidence to really guide your decision making. So I would like our two panelists to give some final comments, and then we move on to the post.
Mustafa has been raising the hand again. I don't
Yeah.
know.
Yeah, Mustafa, please proceed.
Yeah, so I think there was a question about you can say like a CT scan with a contrast in the you can say like low GFR. Just wanted to tell something from our side what we do. So our guidelines are up till 30 EGFR that we proceed with this without IV hydration. But if it's below 30, then we prefer the patient to have IV hydration at least 24 hours after that. But now currently with the renal physicians discussions, that threshold has gone to 20. So just to give some idea about this.
Thank you, Mustafa.
Before we close, I just wanted to go back to that discussion on the nuclear scan. Just because this patient has developed increased metastasis at newer site, should it not be called as a progression? Though he may have had regression at prior sites, but now we have two new sites which have come up. So logically, this should be labeled as a progression.
Yeah,
What do you
definitely. I
think?
think this is what Pilar also pointed out in her initial comments, that we are not able to quantify and give a clear answer in our post-operative imagings to really say that this is a progression, a new disease appearing. So these are microscopic metastases which your PET scan has missed, and some of these nodes have responded, the others you got a new set of lymph nodes appearing. So this is progression.
We are applying the RECIST to the molecular imaging. This is completely out of any question. But it's we start to have already responses and evaluation in prostate, but of course not in UTUC for the rare. You said yes.
Thank you very much, ladies and gentlemen. Wonderful discussion. And if you guys feel like you can log off, we will be moving to the next section in which the MCQs will be displayed on the system. You can download this link and start your test. So
Success to all of you.
Thank you very much.
Thank you. Good night.
Thank you very much. Yes, sir. And Panchayat. Have a nice weekend. Bye-bye.
Bye. So, Sharif, would you be sharing the link?
Yes, sir. I already shared in the chat box.
Okay, perfect. You guys know what to do. So we're starting at 12 minutes past 7. You have 30 minutes. Even if you want to take a little extra, that's fine. Do let me know if any of the member has a difficulty in getting the MCQs. Sharif, I think somebody is asking for the MCQ link on the WhatsApp. I think you already shared.
Yeah, already shared, yes, sir.
Okay, perfect. Thank you.